Persistent discharge from a single duct, particularly if it is bloody, rust-colored, or multicolored, suggests the presence of an intraductal lesion, such as an intraductal papilloma. While these are often benign, they need further exploration with a general or breast surgeon. Paget's disease is a crusty, flaking lesion associated with an underlying breast malignancy, invasive or in situ. While the appearance may be suggestive of Paget's disease, the diagnosis is generally confirmed by a nipple biopsy. The onset of the lesion is often so gradual that by the time it comes to the attention of the physician, many months or even years have passed since its onset. Treatment depends on the character and the extent of the underlying lesion. If a dominant mass is found in the breast which persists through the menstrual cycle, it's usually biopsied, either through fine needle aspiration or excisional biopsy, depending on the clinical circumstances. Suspicious masses are usually biopsied right away. These would include masses that are large, irregular, hard, fixed in place, having redness and dimpling of the overlying skin and nipple retraction. Most masses are benign, but for those found to be malignant, earlier intervention is thought by many physicians to lead to improved chances of successful treatment. Breast cysts present as smooth, non-tender masses. They will often disappear over the course of the menstrual cycle, but those that persist will need further evaluation. Cyst aspiration is frequently attempted using a small needle and syringe. Aspiration of the cyst fluid is performed primarily to confirm the fact that it really is a cyst and to decompress it. Many physicians discard the cyst fluid unless it is bloody, as cyst fluid cytologic examination is felt to be of little value. Following decompression of the cyst, the patient returns for periodic follow-up to look for recurrence. Recurrent cysts in the same location are often subjected to excisional biopsy or fine needle aspiration biopsy. Fat necrosis presents as a breast mass with surrounding ecchymosis. It may be tender, and a history of breast trauma is identified in about half the cases. Even when significant trauma is not identified, trauma is still felt to be the general cause of this condition. This benign condition is self-resolving, but is of clinical importance because it mimics the dominant mass found in breast cancer. Those cases with a typical presentation can be followed to make sure they completely resolve. Those cases that are not typical, or if there's any doubt, can have a fine needle aspiration to confirm the diagnosis. Fibroadenomas are common, benign, solid, round, or oval breast tumors, and they are most common among women ages 15 to 35. They're rubbery in consistency, mobile, and non-tender, and they rarely grow larger than 2 to 3 centimeters. The diagnosis is usually suspected on physical exam and confirmed with fine needle aspiration or excisional biopsy. When found in teenagers, we often simply watch them because of the very low risk of malignancy compared to the architectural disturbance caused by excisional biopsy. Breast cancer is a relatively common cancer, representing about 30% of all cancers in women. In broad terms, treatment is successful in about 3 out of 4 patients in controlling or eliminating the cancer. In about 1 out of 4, the cancer proves to be fatal. The risk of developing breast cancer increases steadily with increasing age. It is rare among women under age 25, but it does affect nearly 1 in 9 of those women reaching age 90. A number of factors are associated with an increased risk of developing breast cancer, including a strong family history of breast cancer, menopause after age 55, or no term pregnancy prior to age 35. Despite the increased risk, about 80%, most breast cancer occurs in women not at increased risk for developing a breast cancer. For that reason, efforts at early detection are not focused just on those with somewhat increased risks, but on all women. The primary strategy involves a 3-armed effort: periodic or annual professional breast exams, monthly self-breast exams, and mammography at appropriate intervals. The underlying assumption of all breast screening programs is that if we can detect a breast malignancy when it is very small, then the outcome will be better for the patient than if we discover the problem when it is bigger. Just how true that assumption is and the exact parameters of that truth are still under debate, as is the effectiveness of any of the breast cancer screening programs in improving outcome for women with breast cancer. Once a year, a woman's breast should be evaluated by a qualified health professional. Any significant abnormalities in texture, contour, skin, any palpable masses, retractions, dimpling, or nipple discharge will require follow-up appropriately for the abnormality. Professional breast exams are felt to be about 80% reliable in detecting significant breast abnormalities. Once a month, a woman should examine her own breast, looking for changes in appearance, texture, or nipple discharge that was not previously present. Examination technique is not obvious, but is a skill to be learned and taught. Any new findings should be promptly reported to the woman's physician or other qualified healthcare provider. Most breast cancers are first noted by the patient herself. Some critics of self-breast exams observe that they may cause more problems than they solve. By the time a breast cancer is large enough for the woman to feel it herself, it's not likely to be an early breast cancer. Further, most of the self-discovered breast lumps are benign and do not represent a threat. Nonetheless, they are often subjected to investigation, including biopsy and excision. The goal of mammography is to detect very early cancers or precancerous changes before they have a chance to develop into a more advanced and dangerous stage. Mammography is felt to be about 80% effective in detecting significant breast abnormalities, but many of the ones that are missed by mammogram can be detected by examination. There is ongoing controversy over how frequently mammograms should be performed. If there is a clinical abnormality, mammograms can be used to gain additional information about the abnormality, in other words, a diagnostic mammogram. Many physicians recommend that screening mammograms be performed every other year between ages 40 and 50 and annually thereafter. Some physicians dispute the usefulness of mammograms prior to age 50. Some physicians recommend mammograms more often if there is a strong family history of breast cancer. Some physicians dispute the value of screening mammograms after age 75 or 80, and some physicians dispute the value of screening mammograms at any time. Breast ultrasound is used in some countries, although not commonly in the United States, to screen for breast cancer. It has the advantage that it is relatively inexpensive, quick, painless, and uses no radiation. It is particularly good at detecting cystic masses, probably better than mammograms. In skilled hands, it does a fair job of detecting malignancies. Unfortunately, it's not as good at detecting malignancies as mammograms, and so it's not usually used for primary screening in the United States. It is commonly used in the United States, however, as an adjunctive method to identify abnormalities palpated by the examiner or identified on mammograms. Thermography is a means of looking at the breast with an infrared or heat-sensitive imaging device. It relies on the principle that cancers have increased metabolic activity, generating more heat that can be detected with the thermographic process. While this has some theoretical advantages over other imaging techniques, in practice, thermography has not been demonstrated to be effective in early detection of significant lesions, and so it's not generally used as a primary screening technique. MRI, or magnetic resonance imaging, is sometimes used in the diagnosis and management of breast cancer. It changes the surgical management in as many as 1 out of 4 patients if performed preoperatively. In high-risk patients, in other words those with a lifetime risk greater than 20%, it seems to have greater sensitivity at detection of malignancies not found on routine mammograms, breast ultrasound, or professional breast exams. Unfortunately, MRIs are significantly more expensive than other methods of detection, limiting their use for screening in the general population.